السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. Thank you, Dr. Abdullah. It was a very, very interesting presentation. It's highly advanced. You really went to the extreme of our, the aims of our course, where we're going into each bit and detail, and you're going systematically from the simple definitions, some conventional methods, and then going immediately jumping into the advanced and the most advanced. So it was very beautifully presented. We really enjoyed it. Do you have any questions? Dr. Osama, you had something you said, so can we repeat it, please?
Yes, Doctor, I had a question about is there another way of transferring the lateral records of the mandible digitally other than using the system, the software system, or the digital face bow?
You mean the armamentarium, the one that uses
Yes.
digital transfer of the dynamic position of the TMJ?
Exactly.
Okay. The armamentarium, it gives you a dynamic on-the-spot feedback. So you know exactly where the mandible is in comparison with the maxilla. So it has sensors and it is related to the same software that they are designing on. Now, if you don't have those advanced tools and that advanced software, you can either use what was reported in when they took an image with the teeth in RCP position. They placed 2 layers of wax, and that will only give you the retruded contact position or even pre-contact because it's open, okay? When you scan the mandible with the wax in between, and you have digitally or manually manipulated the mandible to the RCP, what you will get a scan with the material inside, okay? The material, the 2 layers of the wax are scanned together. But Dr. Mohammed Zawi told me, because we had that idea for research, and I'm still open for this research, no master student took it. The idea is that if we do superimposition, so I had an intraoral scan of the mandible alone, I had an intraoral scan of the maxilla alone, then I take this bite where I'm in RCP. When I do superimposition, it will give me the bite as if it's that bite, okay? It will eliminate the scan of this wax in between. Did you understand it? Dr.
Yes, Doctor. Yeah.
So it's similar to when you take a mandible alone, maxilla alone, then you put the patient in maximum and intercuspation. What will it do? By superimpositioning the images, it will know exactly where is the maximum intercuspation point. But rather than putting the mandible in the maximum intercuspation, you drag it backwards to the RCP, and there you record with the correct separation, it's the 2 millimeter, you record a new scan from the side, and then you do superimposition of the images over each other. So it will give you, rather than maximum intercuspation, it will give you the retruded contact, not contact position, pre-position with 2 millimeter separation, okay? So that's one way to do it, even with our regular conventional CAD/CAM armamentarium. The second way to do it is what Dr. Abdullah presented in one of the papers. They used a virtual articulator. It might be a fully adjustable articulator, but the idea is it allows you with all of the options. But for that articulator to work, you need to provide it with multiple images. These are the same that we provide for semi-adjustable or fully adjustable articulators. When we want to adjust the angles on the articulator, we bring a record of the full protrusive, full lateral protrusive left and right, correct? And the full retrusive position. So imitate that, doing those exact positions, but with a digital scan on the side. So once more, it will superimpose the images, virtually calculate the articulator angles, and then mimic the movements of the TMJ in it, using that articulator. Is that okay? Does that answer you?
Yes, Doctor, thank you.
Okay. Dr. Abdullah, it was an excellent presentation, and you went through some of the trying to work with the screen. Okay, you worked with all of these very wide range of subjects in a very smooth way. as we said, systematically, where you had put every subject from the very basic till the most advanced very smoothly. So you advanced in the subjects very well. You classified it, you worked with that, signs and symptoms, you talked about the epidemiology, diagnosis, how we diagnose them, the techniques of radiography. And then all of this, you connected it with the later subjects, especially the CBCT. You talked about the MRI, talked about the magnetic resonance. These are new advanced devices where they do further imaging with further abilities using TMJ specific images, okay? So I love this subject. Nothing to add here. It was well advanced, well explained, and anyone interested in such research using those devices can simply just look up the research and go through it. Okay, but when you went into the TMD, you talked about conservative treatments and invasive treatments. You just passed here where we were talking about physical therapy, but here's the cognitive therapy. Okay, before going into these subjects of manipulation, I would advise you to go into relations of the TMD with systemic diseases or systemic situations. I sent you on the WhatsApp some of these. For example, depression, it's a psychological problem, okay? Or anxiety, it's another psychological problem. These are closely related to the TMD. They have some correlation and you will have studies linking them together. So try to put them as a category in terms of TMD and physical and psychological health, okay? You will also find with the physical health, you will also have the fibromyalgia. It's another disease that has many times some TMD presentations because the muscle pain, where the lesions are or the nodes are of pain, some of them appear in the muscles of mastication. So you will have the signs of the fibromyalgia in the masticatory muscles of the TMJ. Also, you have sleep apnea. It's another condition that is closely related to TMD. And it talks about the correlation between having no oxygen at night and the mandible trying to find a place where it could open up the airways. So the clenching and bruxism occurs because of this. So there are some also relations with sleep apnea. So I would advise before going into the management of TMD, just mention the correlations of TMD with other health problems present in those patients, okay? Then you talked about self-care techniques, and I love this as well because self-care techniques makes the symptoms relapse. So no, you don't want avoiding the causes of TMD could be controlled, simply controlled by these habits, new habits. Okay. So patient education, exercise guidance. I love the way you talked about cognitive therapy, where patient could reduce. But once more, this is treating the anxiety and depression. It's not actually treating the TMD itself. It's treating the TMD through reducing the anxiety and depression. So this is why the importance of putting in the overall health problems related to TMD. And then when you're talking about each therapy, you're relating it to each one of them. Cognitive therapy, systematic reviews, you talked about them. Biofeedback, I love this device. It provides the biofeedback. It could tell you if the muscles are relaxing using any of the methods you have used earlier. For example, you talked about physical training of the TMJ. So using this device in conjunction with those therapies will give you immediate feedback on are you targeting correctly the painful muscles or not? Are you making them rest or not? So I love this work. I loved where you talked about these toxins, which are like Botox and so on. But these, I loved the way you categorized them as well. And those are easily understood from the slide. I loved it. But once more, you need to relate it to having medical degree. Please add in something here to refer that these are applied by medical degree patient practitioners that have a medical degree, allowing them to do that. For example, what I know as a general rule, I'm not sure about this case and about this study, but what I have as a general rule, I remember that Botox should not be injected below the nose, Frankfurt plane, between the nose and the ear. Anything below could infuse and affect the larynx and the throat. Okay, so having these treatments recommended, these pose a large hazard for the patients. So make sure that you highlight what are the limitations of such injections, and do put it in very bold that a medical practitioner, specific, who is a certified medical practitioner, is the only one allowed to use these toxins. Because we have this trend where everybody in dentistry is going towards using Botox and fillers, even if they're dentists and they're not aware of these limitations and hazards of these toxins. So please add that here, okay? Definitely toxins will reduce the pain because you are simply reducing the spasm of the muscles, but have you removed the cause? Is it going to relapse? You need also to work on this, meaning for how long do this affect? Do you remember that we talked in one of the earlier, I think it was your presentation where you talked about the time limit for each chemical. So how long will it work? So repeat it here, where you talk about each one, how long it will be expected to work. And then as well add in the limitations of having a recurrence of TMD, if the main reason of the TMD is still there. Okay, intraoral appliances, I loved it. The classification of the appliances is so advanced. I liked it very much. I loved where you talked about the hydraulic one. Where was it? Yes, this one, the hydrostatic splint. I loved it as an idea where you equalize. It's beautiful, but you also worked with their limitations. I loved where you talked about the limitations of each one. If there was one, if I have missed one with the limitations, just please tell me, okay? In one of your slides, you talked about how you confirmed that you have treatment or remission of the symptoms if you had absence of retrodiscitis. If on that slide, specifically where you talked about the retrodiscitis, try to correlate that diagnosis with the correct diagnostic tool used to confirm this. So if I'm going to talk about retrodiscitis, how do I diagnose it? Try to look for the tools you talked about earlier and mention it here. Okay, just mention it. And this is confirmed by using so-and-so device or so-and-so symptoms. Okay? So, also these researchers had talked a lot about the sense of patients coming back. I love this. Try to capitalize it even more. The patients should come back for recall. And they talked about the tools. Now, I would like you to put a slide for the tools used to detect remission of the symptoms. For example, if you're talking about TMD, we're talking about charts. You talked about TMD charts and or measuring scales. Put them in, and I would like you to add one, which is called TMD research tool, okay? I have it. I have a copy of it, and I'll give it to you. It's like a chart that expands all of the muscles of mastication and gives you a method for their palpation and their massage and trying to score the pain from 0 to 10. So it's easily applied. Everybody can understand it. It's different from the patient-only reporting. Okay, so I'm afraid that some of these studies have only concentrated on patients' symptoms rather than looking for signs and doing actual examination. Okay, so try to put them into symptoms and signs of TMD in terms of recall. How do I get feedback that this TMD is reduced? Okay, try to select those tools from the studies you have and add the one I'm going to send you in a moment. Okay. As I told you, what's specific about this research tool, it could put the pain into numbers. Okay, so you can use it in research and you can use it even for the patient themselves when they talk about what does 10 mean, what does 0 mean, and so on, or 1, for example. It could be 0 to 10 or 1 to 10. But it's
Doctor, should I?
Yes.
Okay. Should I add it in a separate slide or?
Yes, the research tool, yes, because I love the image they have. They have a specific image, a chart where you put the numbers on. Okay, and they
Yes.
also provide you with statistics for, so you're going to put in also the website for them. It will be very useful for anybody doing research on TMD. Okay. When you talked about CAD/CAM designs, okay, you talked about occlusal splints. You talked about the material. I love this slide. I loved where you talked about the ways that are additive, not subtractive. Okay, but if we're talking about here, first of all, I want one slide at least giving me the options that a software provides. For example, if you go to our school, go to the CAD/CAM system that we have and see, show us, take images and show us what are the options for the splint design. What do they provide you with? Are they all are in RCP position, or are some of them in advanced mandibular position, or what? Okay, if you can find that there is a software that gives you more options in terms of the design of the splint, the hard splint, please also put it in. Okay. So, for example, what I get from your slides, if I'm going through, I could only see a full arch splint, and I would expect that it's in RCP. Is this correct?
يس دكتور. هسه الفكرة إنه لو تقدمي سلايد لقدام ممكن.
Okay.
Yes, here يعني I concluded the fabrication process. I think in step 2 here we are designing the splint, and we can determine the extension of the splint and the direction of insertion. So we determine the design of the splint, but I cannot determine now.
Okay, if I want, for example, to produce a mandibular advanced position, can I produce it using CAD/CAM? Or is this only
I don't know.
regular conventional designs? This is what I want exactly. How can we do other types of splint shapes? You've talked about many splint shapes using heat cure.
Yes.
Does the software provide me with multiple designs so I could use them?
Yes.
Are there these designs in the software or not? Okay, just like this. Begin with the CAD/CAM we have, and then check for other CAD/CAMs. Do they provide you with other designs for the splint? On this slide, exactly, where I was going to talk about something. First of all, let me go back first. Okay, this was one of the images. Okay, you're talking about this. Sorry, I'm going downwards. I needed to go up. Okay, this study by Baylor, they talked about 2 millimeter and 4 millimeters thick splits. Where did they measure it? If I'm looking at the image, if I'm looking from the image, okay, I'd expect that they had measured it anteriorly. While our recommendation for the acrylic to be prolonged, to stay in prolonged use because of its structural weakness, is that the 2 millimeters should be backwards. Just recheck this study. Where was the 2 millimeter measured in between arches? Is it anteriorly or posteriorly? And highlight it, please, okay? Because what I see from the images that the 2 or 4 millimeter are from the front, measured from the front.
From the premolar area دكتورة هم عملوا الميجرمنت. بتوقع في بلاك سبوت لو شفت على البريمولرز هسه حاليا.
But still, you need to check where did they measure the 2 to 4 millimeter or 4 millimeter also. Did they measure?
I'm sure إنه at a premolar area.
Try to find the text and highlight, because 2 millimeter at premolar area is too thin still. Still thin, صح? Because we wanted the 2 millimeter posteriorly between the molars.
Yes.
Okay. Going down here, where we talked about this design. Okay, I had to comment on this design. Where is it? Sorry. Yes, this one. When they worked with this design, if this paper came to me for a review, I would immediately comment on the position gingivally of the night guard. The night guards gingivally, you remember the rule for gingival cleansing ability, we need to have the night guard 3 millimeter above or below. Okay? It's either above the gingival line or below the gingival line. And in some areas it could reach up to 6. Okay? So this design that we have here, I think it's traumatic for the gingiva. It might accumulate plaque and so on. This is just a comment, okay? This is just a comment.
Yes.
Why do I need you to highlight it in a sentence? Write it down here. Just put a note. Note the gingival margin position of the night guards should be, or the occlusal plane should be reevaluated for gingival health. Okay. And put in the rule in between parentheses, what is the correct measurement away or below the gingiva, okay? Above or below the gingiva. And also you need to talk about, this is a very essential, that you need to talk about arbitrary blockout. Because also, even if we're covering correctly, which is 3 millimeter above the gingiva, if I'm doing that, I need arbitrary blockout, where I'm covering the gingiva 1 to 2 millimeters with plaster or stone or whatever. I have to block those out because I don't want the acrylic going into the marginal gingiva morphology like a triangle, a sharp triangle, and that can produce pain and accumulate plaque and all of the problems. So you need to add two things: the position in terms of the gingival margin, and second, the essential presence of the arbitrary blockout around the gingival margins. Okay. Do you remember the arbitrary blockout from cobalt chromium prosthesis? Where we protect the gingiva, we fly over it, actually. We don't go with the morphology of the marginal gingiva with a C shape going into the early clavicular space. No, we cover all of the clavicular openings with arbitrary blockout. So the appliance actually runs from the attached gingiva, flies over the attached gingiva, the marginal gingiva, and touches the tooth above it by 2 to 3 millimeters. Okay. So after that, okay. When you talked about 3D printing, you just mentioned the resin they use, okay? Because 3D printing is different than CAD/CAM material, okay? Just mention what is the material that could be put in through a 3D printer tip, okay?
As a material, Dictora, as a commercial types?
Not a commercial, I just mentioned, because you know, a 3D printed material, you have two types of 3D printed additive by having some resin or plastic or whatever running
Yes,
through
yes, stereolithography.
Yes. It's different than creating it through a powder, for example. And is there something with a powder, for example, with acrylic powder? So just mention what are the material that could go through a tip, because for polymethyl methylcrete or P, I don't think that can go through a 3D printing tip. It doesn't come tubes, and you can heat it and relocate it into the position. So I would expect that they are using another material other than acrylic, other than the PEEK. Okay.
Okay.
Just mention what is the material and what it's made of. Extensions, yes, Badora, I talked about it. Okay. Images of occlusal adjustments. The system is great. I loved looking at the system. The invasive treatments here in occlusal adjustments, we need a little bit, just one addition, please. And try to get that from images, from either from slides, actual cases, case reports, or whatever. What I want, I love these images, but I want the before, then after, okay? The before, then after, because it will give you a better storytelling than the images after. We all know where the teeth should be contacting each other. The idea is how to detect, using the colors of articulating paper, how do I detect a presence of an interference? How does it look before? How does it look after the adjustment? Okay. For example, take this one. If I had some interference, because suppose we have a crowded lower anterior teeth, okay? One of the crowded incisors is going forward. What will I have? I have only one strike on the central. All other teeth will now not have strikes. So, because that tooth is higher, supraerupted, and
yes,
but more anterior. So it will be better telling me what happened before and after, okay? So I will have, for example, 1 or 2 And usually what I'll find, I have periodontal disease here and in the lower because of the occlusal trauma, because of the high contact. So what you explained in text is excellent, because this is part of our work as a prosthodontics in prosthodontics as prosthodontists. But the idea is before and after images will give you a better storytelling. Okay, you can bring the two. For each one, for example, the excursive movements adjustments, 1 or 2 slides, just images for one case of adjustments, anterior adjustments alone, and so on. Just 2 or 1 or 2 slides for each, showing cases where this is before and this is after. It might bring you, you might have in case reports, for example, you might have intraoral images from the patient. So the idea is with images before and after, it will be better understood. Okay. Nothing to go to the nothing to say about the arthroscopy, because this is oral surgery, but it's an option you need to know about. Thank you very much, doctor. It was an excellent presentation, and see you inshallah in the next one. Inshallah.